Welcome to another edition of This is Public Health, a podcast from the Illinois Department of Public Health. We're continuing our series of podcasts taking a deep dive into the main priorities laid out in the Healthy Illinois 2028 State Health Improvement Plan. This time, that focuses on one of the enduring pillars of public health addressing chronic disease. Later, we'll be joined by Dr. David Chung, a doctor of family medicine and a member of the Illinois State Board of Health. But joining us first, we're honored to have with us Dr. David Ansell, Chief Health Equity Officer and Senior Vice President for Community Health Equity at Rush University Medical Center in Chicago. Dr. Ansell, thanks so much for being here.
Thank you for having me.
I want to begin by making sure we all understand the terminology that we're using. So, what do we mean when doctors and public health professionals refer to chronic disease?
Chronic disease is um, an illness that you can have over a long period of time. So we distinguish between acute illnesses, for example, a virus that might last a few weeks, or a pneumonia, or even a bout of gastroenteritis, which are acute illnesses. But chronic illnesses oftentimes last for years and years and years, like osteoarthritis, like some forms of cancer, like cardiovascular disease, for example. So you could be diagnosed with cardiovascular disease at a young age and carry it for many, many years. HIV, another one, where it's not an acute illness, though in the case of HIV, there's an acute phase of HIV, but the illness itself is a lifetime illness. So that's what we're talking about with chronic disease.
And obviously, potentially very serious conditions that can have a profound impact on someone's quality of life, which is why it's one of the priorities laid out in the Healthy Illinois 2028 plan. Now, recognizing that every disease is different, are there some commonalities among chronic diseases? And in general, are they preventable?
Well, it's a great question. From a public health perspective, we often think about prevention as being central to our work. And many of the chronic diseases that we're referring to are preventable. And let me just give you an example of kind of how we're thinking about it at our institution, but it applies statewide. In Chicago, there's vast life expectancy gaps that exist between neighborhoods. And this is a phenomenon not just in Chicago, it's across Illinois, and across not only the country, but the world. And sometimes neighborhoods quite close to each other have large life expectancy gaps. I can just talk about the neighborhood I'm in at the west side of Chicago. The Loop, the life expectancy is about 90 years old for that neighborhood. You go to Garfield Park, literally a couple of stops past Rush, 7 stops down the Blue Line, and the latest data from 2022, the life expectancy is under 63.9. It's a 25-year plus life expectancy gap. The number one driver of that life expectancy gap are chronic conditions, cardiovascular disease, and cancer. People don't think about that. They think of a neighborhood like West Garfield Park, which is the one I'm referring to, which, if it were a county, would be the lowest life expectancy county in the United States. Think Sioux Nation, Pine Ridge in South Dakota. And yet, the largest contributor to that life expectancy gap is cardiovascular disease, cancer, and chronic diseases like that. Now, there is other things, homicide and overdoses. You could look at addiction as being a chronic disease. If you have an alcoholism or a drug addiction, that could be a chronic disease. And therefore, the overdose, which seems like an acute event, which it is due to the chronic illness. So largely across the United States, we're dealing with an epidemic of chronic illness. And when you break it down to the subcomponents, I've been talking about heart disease and cancer, but liver disease and other diseases as well. It's led to a very large growing life expectancy gap in the United States since the year 2000. So it's a critical public health problem. And it's not about the money we've had invested in healthcare. because we've got enough money invested in healthcare. It's about our attention to those conditions in those neighborhoods, which we call the social structural determinants of health. So we need a more complex approach to addressing these chronic illnesses.
This ties in directly to your expertise as a health equity official, and we'll come back and talk more in depth about that. As you mentioned, heart disease, February is National Heart Month, and IDPH and many health organizations are engaging in a full-scale public awareness campaign to encourage people to be heart healthy, something that happens every year, and yet heart disease remains a leading killer of Americans and number one killer here in Illinois. Why are heart disease and these other chronic conditions still so prevalent in our society?
Well, that's a great question. Well, there's many. Uh, Generally, for bad outcomes to occur, you need more than one root cause. But let me just name a few of them right here. S so, um, it is the number one cause of mortality and premature mortality, and it has a number of root causes. So number one is obesity. Rising obesity is directly correlated with rises in heart disease. And generally through other factors, elevated lipids, which you can connect with obesity as well. But people who have elevated cholesterol levels uh, have higher risk of getting and dying from cardiovascular disease. Three, maybe the number one controllable variable to reduce heart disease and stroke mortality is high blood pressure, hypertension. And people oftentimes think of blood pressure over 140 over 90 as being high blood pressure, and that is at stage 2. But hypertension starts, we call it hypertension when your blood pressure is above 120. And a lot of people say, well, my blood pressure is normal. Well, it actually might be slightly elevated. And at every level of blood pressure increase, even at those low levels, confers greater risk of heart disease and stroke. Things that people go around and say, oh, I'm normal, but it's actually best to have a blood pressure that's less than 120. And so I don't think there's a high degree of awareness about that. But then let me just talk about this intersection. Again, I'm about neighborhood effect. Not only am I a general internist who practices for many years now, but I'm also a public health person and social epidemiologist. And one of the observations I had in my patients were, what was it about the neighborhoods they lived in that conferred risk? And there's something about neighborhood conditions, particularly where disadvantage is concentrated. When I say concentrated disadvantage, it could be poverty, poverty, residential segregation, uh, the lack of jobs, the lack of safe places to walk. These things as well seem to be correlated with higher rates of cardiovascular disease. And there's probably, there's mechanisms that have been studied through stress, and the stress of daily life and the cumulative impact of stress itself. Of course, I didn't mention smoking, which has to be thrown in there as well. So when you sort of look at heart disease, not only incidence, but mortality, in particular premature mortality, the conditions in the neighborhoods that people live have a negative impact on the biological factors that cause heart disease.
And again, we want to delve more deeply into that health equity question here in just a moment. But another factor that I think has really altered the overall approach to chronic disease, we noted that it has long been one of the linchpins of public health. But of course, a few years ago, when the COVID-19 pandemic struck, that shifted a lot of the focus, and a lot of efforts were focused on that immediate public health emergency. Now that the pandemic is over, how are we rebounding from that? And how are doctors and health professionals doing in reminding people that this is also a critically important part of their overall health in talking about disease prevention?
Yeah, so you ask us an important question that's loaded at the same time. So one of the things that happened during the pandemic, was when we had the pandemic, right? A new virus. But what we found pretty quickly that it rooted itself in pre-existing conditions, social conditions, but also chronic disease conditions. It was not the great equalizer, right? We all lack immunity, so we all must be at the same risk. But in fact, what we saw that it disproportionately impacted people of color and people with chronic diseases. So what we actually had was a syndemic. One epidemic crashing into another epidemic. That's called a syndemic. But the underlying epidemic, we hadn't really been paying the kind of attention to that we needed to. I said about the year 2000, we began to see overall life expectancy in the United States beginning to drop, unlike other developed countries. And when you sort of looked at what was the reason for it, and more people died in the decade, say 2000 to 2010, than it died in the whole AIDS epidemic, and yet it went almost unspoken. And these were largely because white people in the United States without college degrees were dying of unprecedented rates, to the degree that it dropped all of U.S. life expectancy. So we've had, and so the experience of people of color is also, with regard to health, has never been ideal, particularly for Black people, American Indians, indigenous folks. You had this COVID epidemic crashing, colliding with this pre-existing epidemic that had not really been acknowledged. And then, of course, you had disproportionate COVID deaths, but then you had disproportionate deaths from other conditions as well post-COVID. Chronic diseases being one, and car accidents being another. In a place like Chicago, there were homicides and drug overdoses. And insofar that those other causes of death that were exacerbated by the COVID epidemic and, in the conditions under which people lived, worked, and played, created a disproportional mortality rate and from other conditions, from chronic diseases, accidents, overdoses, injury, in the same communities that were devastated by COVID. So when you look at that life expectancy gap I described between the Loop, Chicago Loop, and the west side of Chicago, what happened is the Loop recovered more quickly from COVID, and therefore the life expectancy gap got bigger between these other neighborhoods because it wasn't just COVID. It was these other causes of mortality, the pre-existing epidemic of chronic disease.
Which brings us back to your particular area of expertise, that being health equity. Talk about that in terms of chronic disease and some of the key things that we as a state and nation should be doing or could be doing better to address this life expectancy gap that can be so stark from community to community and even from neighborhood to neighborhood.
Yes. I'm glad you asked that question because it's an apropos time. We have a new administration, and actually we began this work back in 2017, full force at Rush. And we've been doing this now for 8 years, really thinking about those community determinants of health. And by the way, as I've described today, it's really about communities that are experience concentrated disadvantage, that are worse off, okay, from this. But, we call it a health equity strategy. But at its heart is diversity, equity, inclusion. 3 words that have gotten maybe some bad press recently, and I think have been maligned inappropriately because the center of our idea about diversity, equity, inclusion, and particularly health equity, is the idea that everybody deserves a chance to be healthy, regardless of race, ethnicity, gender, age. But we do have to acknowledge that the neighborhoods with the lowest life expectancy, with the biggest risk and exposure to chronic disease, are poor neighborhoods. And at the bottom of our poor neighborhoods are you know, uh, you know, historically segregated communities, Black neighborhoods in general, but not exclusively, uh, Indian reservations, and uh, neighborhoods across the country where there's high concentrations of poor white people. And if we take a neighborhood approach to this work and say everyone deserves a chance to be healthy by access to healthcare, by access to, uh, prevention, access to healthy places to exercise, healthy food, and those things, that's our notion of equity. And it's not one where it's, preference for one, group over another, but it's acknowledging the fact that for conditions for which healthcare can make a difference across the United States, across every health system in the United States, there's a black-white gap in those outcomes, and oftentimes uh, an Asian white and a black Asian gap, in which Black and American Indians are performing the worst on conditions for which healthcare can make a difference. So as we focus on equity, we think about those who need more and how do we get them the resources they need? And how do we design actually our healthcare and our access in a way that addresses the true needs of the people? Let me give you just a really, really explicit example from COVID that everyone remembers. So one of the recommendations of COVID was everyone should get a vaccine. Of course, there was vaccine mistrust, but we had another problem is that of course, naturally, these chain pharmacies in the United States were given large doses, large amounts of vaccine because it was a great way to distribute vaccine. But I can tell you, and it's gotten worse since the pandemic, telling a patient to go to Walgreens or CVS when they live in a community where there's no Walgreens or CVS, and they don't have a car or transportation. So I can tell you, prior to the pandemic on the Black West Side of Chicago, maybe 250,000 people, and there tend to be Black neighborhoods because of residential segregation. Other people can live there, and people go there, but they're largely African American neighborhoods. Not one CVS in those neighborhoods. So sometimes we think of recommendations as doctors to say, go get your vaccine at a Walgreens or CVS, and those facilities are no longer there. And again, we've seen a big washout recently. And that creates an added disadvantage. On top of you've already got a disadvantage because you're poor. And now we got a disadvantage because you don't really have the same kind of access to care. In my neighborhood, right outside of Chicago, my God, you go to two corners, you get CVS, Walgreens, they're everywhere. But the folks in the next neighborhood over Austin, in Chicago, have to travel into Oak Park if they want to go to a pharmacy. So we don't think about these things. So they're pharmacy deserts or swamps, and they're food deserts or swamps, and these things contribute to poor health.
And this is why chronic disease through a lens of health equity is one of the main priorities in the State Health Improvement Plan, Healthy Illinois 2028. We'll delve more deeply into some of those goals of the plan coming up here in just a moment. But first, I want to say thank you to our guest, Dr. David Ansell, Chief Health Equity Officer and Senior Vice President for Health Equity at Rush University Medical Center in Chicago. Dr. Ansell, thanks so much for your time. We do appreciate it here on This is Public Health.
Yeah, thank you. Thank you so much for having me.
And as we continue now on This is Public Health, where they'll look at chronic disease, one of the main priorities in the Healthy Illinois 2028 State Health Improvement Plan, we are pleased to welcome our next guest, Dr. David Chung. He's a physician from Sparta in Southern Illinois, specializing in family medicine, also a member of the State Board of Health here in the state of Illinois. And Dr. Chung, thanks so much for being here with us.
Well, thank you for inviting me, Jim. I appreciate the opportunity to speak on these topics.
As we've been discussing, focusing on chronic disease because it is one of the 5 main priority areas in that State Health Improvement Plan, and the State Board was so instrumental in developing this plan. So why do you see this as a major public health priority here in Illinois?
So, chronic disease is absolutely a focus for the Illinois Department of Public Health SHIP plan, Healthy People 2028. when we think about chronic diseases, we probably think about diabetes and heart disease and cancer, lung disease. And when we're young, we kind of think about these conditions as something that happens when you're older. But we now realize that many of these diseases start when you're younger. And it's important to know what the factors are that can help modify and prevent these diseases before you need to see your doctor regularly for your diabetes checkup. So, absolutely, it's important to identify and to recognize what are ways we can actually prevent these diseases from occurring. So, the focus for the public health is not just diseases per se, because as a family physician, we do know that individual, management and with your diet and exercise and medications with your physician and it's very important. But for a public health perspective, it's important to realize that there's factors involved that hopefully we as a nation, as a state, can enact to help people be healthier. So I'll give you some examples of what chronic disease, as I mentioned, like diabetes and heart disease. We realize that obesity is a major role in those two conditions. Also, for asthma and chronic lung disease, smoking is absolutely a role in that. And as we look at cancer, obesity, heart, smoking, it's highly associated with cancer. So as we look at the things that we are exposed to and the things that we ingest and the activity that we do all have a role in this. So the focus for these topics of chronic disease management and prevention is really probably one of the pivotal cornerstones of how we stay healthy as a state, as a nation.
As you point out in the State Health Improvement Plan, it not only acknowledges this is a major issue, but then also lays out specific goals and strategies for addressing it. You touched on one of these, which is it's laid out as a goal in the plan: increase opportunities for tobacco-free living, since we know the tobacco usage is so closely linked to so many of these chronic conditions. We've done a lot of things right in this area here in Illinois, but are there still challenges that remain to help people live a tobacco-free life?
Well, absolutely. So obviously, we have laws of who can purchase cigarettes and vaping products. So in 2019, federal government moved up the age from 18 to 21 for to hopefully limit minors from buying tobacco products. The Clean Air Act in Illinois is one of the states that prohibits smoking in indoor facilities such as restaurants and public places, like especially like hospitals. I remember talking to a colleague who retired, and people were smoking in a doctor's room because that was part of what they did for relaxation. So these are major things that we've done. However, we're still not quite there yet. So the decline in smoking has improved since the reduction of cigarette use indoors. But scary statistics is that even though we're down to 12.4% of Illinoisans are smokers, and we're down to 2.5% of Illinois high school students are smokers, we're actually seeing 16.7% of Illinois high school students using electronic vaping products. So they're switching from one tobacco to another. And although there's not that many studies available for electronic cigarettes and what to do, we've had some mini crises of people have vaping related lung injury, and we know chemicals that we're not supposed to be in contact with, like formaldehyde, can increase risk of cancer. So we know that there's going to be data down the road that electronic cigarettes are going to be bad for us. But at this point, we still got some room to improve, and there are federal money coming to Illinois to help prevent tobacco use and education about that. But I think that although we are aware that smoking is bad for you, the issue remains is that it's available and people use it. And I, as a physician, every day I have sessions where I talk to patients about, are you interested in quitting smoking? And here's some uh, options to quit smoking. There's the Illinois Quit line that is free to use. Anyone can call in and get advice on how to quit smoking. Most cigarette smoking cessation medication are covered by insurances. So like I won't mention names, but medications that are available. So this is an opportunity for people who do smoke to quit and to improve their life expectancy and to be healthier.
Ironically, in some parts of the state, it may be easier to get your hands on a pack of cigarettes than on fresh produce. Another goal in the state health improvement plan is to decrease preventable chronic disease through nutrition. But we know there are lots of parts of the state, including parts in your part of the state, that are what are considered food deserts without easy access to grocery stores or fresh produce. So, what kind of challenges that create to make sure people have the kind of nutritious diet that can help them avoid these preventable diseases?
Oh, absolutely. So I practice in Randolph County, Illinois, and we're in the southwest area of our state and rural area. And so, we have a big box grocery store in town, but it may take 20 minutes to get there, depending on where you live. And a lot of the mom and pop grocery stores have gone under because big box has taken over. Also the pharmacies too. There's not too many local pharmacies anymore because of that change. But the question is availability of healthy food. So unfortunately, what sits on the store shelves, what's our have packed with preservatives and sugar and salt, they can stay on the store shelves for months without going bad. And so the things that go bad very quickly are the fresh fruit and vegetables. And if you don't have access to that type of food, then it's very difficult to maintain a good health. It's been known that people who are in higher income bracket versus lower income bracket have seems to have more access to nutritious foods such as whole grains and vegetables and fruit. And unfortunately, the cheaper products are ultra processed and high in sugar and salt. And so you gotta eat to live. And if what's available is fast food and ultra processed food that's can sit on your shelves for months, so you don't have to go shopping, every week to keep things fresh. Uh, that's it's difficult to maintain a healthy lifestyle. So definitely, we need to have access to uh, healthy food in every part of the state, rural and urban. Um, there, there's just too many places to get unhealthy foods, such as fast food, versus to get a legitimate salad that's is healthy for you. So
Another area that may be easier said than done is another goal of the plan, increasing opportunities for active living. How can we help ourselves and others be more active?
So being active seems to be a individual choice, and definitely is one of my topics I talk to patients during their physicals. And most people are busy with work and have a hard time balancing work and active lifestyle choices. Um, I will say that my local health department, Randolph County Health Department, last year enacted a program called Get Moving Randolph County. And this program was to get people together to take a nice long walk in a park and monitor their steps and kind of motivate people to have a goal in mind of activity. And at the end of the month process, you turn in your data and you get a free T-shirt. So that was a motivating thing for the health department. I do think that as we move forward, we have to realize that sometimes we just take for granted that there's spaces to exercise. And some counties, some cities, towns don't have good infrastructure. And if the health department can promote access to outdoor venues for exercise, uh, fitness programs at hospital programs or community programs for fitness. It starts in the schools as well. So keeping PE in schools and keeping sports available for not just elite athletes, but for everybody can continue to motivate people for lifelong fitness. But workplace, a lot of people work many, many hours at work and don't get off their chair very often other than eat and go to the bathroom. So there's must be ways to encourage maybe standing desks or treadmills in office or other programs that people can do that in the workplace if they're having to sit for many hours a day. So all these things have to have opportunities. If there's no opportunities, then there's no chance for people to do extra activity when they feel that they're working long hours and don't have the opportunity to exercise. But obviously individual choice to do an active lifestyle, but opportunities and education, because definitely you can get your diabetes better controlled, your hypertension better controlled, risk for heart disease and other chronic diseases improve with regular exercise and active living.
The final goal that's laid out in the State Health Improvement Plan to deal with chronic disease, it says, increase community clinical linkages to reduce the incidence and burden of chronic diseases. Well, as a physician, you're that clinical link there to the community. So in your view, what more can be done, and how can doctors be more involved in helping a community to prevent disease, reduce that burden of chronic disease? What does that partnership look like?
Yeah, that's a very interesting question. Community healthcare workers is uh, a definition that I became familiar with this year from the Illinois State Department, State Board of Health. We talked about community healthcare workers, and I did a little research about them and found out that my county doesn't have one. This community healthcare workers may form a great bridge between the clinician, myself, and the patient and the community. As a physician, I talk to the patients individually and discuss, how to stay healthy. But if there is a community worker, someone who can reach out in the community, a trusted member of the community, such who has training in health and health promotion, that would really improve the connection and trust between patients and healthcare providers. I do think that during the pandemic, there was a lot of mistrust between government, patients, clinicians, a lot of mixed messages, and people didn't know if they should wear masks or wear masks, if they should go to school, not go to school. And as we move forward in promoting public health, we need to have trusted sources from clinicians and the health department, as well as trusted members of the community to bridge that gap between facts and fiction. So community healthcare workers who really like to promote and fund and get that connection going. So I do think that's a major point is to improve the number of community healthcare workers that are able to connect with the community and the patients and the clinicians themselves. One other way is federal health qualified healthcare centers. We call them FQHCs, and that's kind of, for most people, they hear that's like, I don't know what that is. It sounds like a federal funded doctor's office. And it's not just a doctor's office. And we actually, my hospital just set up a FQHC in our town, and it also provides behavioral health and dental health, and it's to promote not just access to medical care, but access to those services as well. So FQHCs also can help bridge community and clinicians as well, because they also provide behavioral and support that way. So as we move forward, is to try to get the community involved, and not just for the health department going directly to their clients, but to get community entities involved. That would really help build trust and education, and bringing that message of that we're all in this together. The people, Illinois, people of the United States, we need to get healthier. We have billions and billions of dollars spent on healthcare, and we're getting sicker and sicker. So the main issues may not just be medication access and cost of medicine, which is talked about a lot, which I definitely agree that we need to get the costs down on that. But the other part of things is prevention. How do we stay healthy? How do we keep the blood pressure control, diabetes control? How do we keep the weight down? And it's great that we have good medicines, but it doesn't replace healthy living and healthy activities. So that, yeah, I really think that getting community healthcare workers, more of them, to link together clinicians and patients in the community together, that'll be great.
You can learn more about community health workers, CHWs, in addition to federally qualified health centers, some of these preventive measures, and you can also read up more on the Healthy Illinois 2028 State Health Improvement Plan. You can find all of that at the Illinois Department of Public Health website, dph.illinois.gov. In the meantime, I want to thank again our guest, Dr. David Chung, family practitioner and a member of the State Board of Health, and then earlier, of course, heard from Dr. David Ansell from Rush University Medical Center. Thank you for joining us here. Join us next time as we continue our look at the Healthy Illinois 2028 plan with our focus on racism as a public health crisis. That's next time on This is Public Health with the Illinois Department of Public Health.